Afternoon, everybody, and welcome to the Board of Health meeting. I'm going to rapidly turn this over to our director, Bobby Locke, and she can kick it off from there. And I know that we have a surprise visitor today, or maybe not a surprise, but I'll leave it with that, and Bobby, you can take it away. Thanks.
Okay, thank you. All right, welcome to the Board of Health for April. Did everybody have a chance to approve the minutes? Oh, let's do introductions first. I'm Bobby Locke, Health Department Director.
Carol Schaefer, Assistant Director.
Amanda Mullen, County Medical Officer.
Katie Maxwell, Public Health Planner, and Happy National Public Health Week.
Woo!
Stephen Tarnowski, I'm the County Attorney.
Kent Lindsay, County Commissioner.
I'm Candelaria, County Commissioner.
Right, so on the minutes from our last meeting in January, everybody good with those? Any changes? Okay, good, okay. All right, so we are good with those January minutes. So, dovetailing onto what Katie just said, it is National Public Health Week. So we are having an open house today from 3:30 to 5:30. We've been advertising it. We've been getting a lot of phone calls about it. So hopefully we get a good turnout where we basically have pretty much every program represented in the department. We can give you a tour, and it ended up that we could actually even give you a tour of our dental clinic, which we didn't think we were going to be able to do, but we can now. So, yes, so hopefully you all will come, and anybody out there in public land that wants to come, be great. We're doing door prizes, drawings every 15 minutes, and I will say they're good door prizes. So hopefully you guys can come, and we have cake. After you're done doing the tour, you get a piece of cake. And I think punch. Did we get punch? Okay. Yeah. So. Yes.
Well, thank you. I appreciate that, and I do apologize. I did have a note on my table to announce it while I had a large group of people here this morning, and I forgot. I was looking through too many other notes, so I do apologize to you all.
Well, that's okay. We did this years ago. Neither one of you were commissioners at the time because it was Keenan. So, so it's been a few years since we've done an open house. This is going to kind of be testing the waters again, see what our turnout looks like, and we'll do an after action afterwards to see how we want to make some changes or improvements if we want to do it again and how we want to do it. So if you can come, that'd be awesome. Okay, so that's pretty much the news about National Public Health Week and our open house today. So I'll move right on to a measles update. I can do other communicables if we have questions, but I think I'd rather spend some more time on, well, obviously discussing measles briefly and then our community health assessment review. So you probably all heard that there was another case of measles on April 7th in the Denver area, and this one is an unvaccinated infant too young to be vaccinated. So there is more specific information on where this case was as far as exposures go, but I'll kind of just touch on the highlights. So this makes 2 cases of measles for the state of Colorado. The first case that was in Pueblo was an unvaccinated adult who had traveled. Had traveled to. They think there's a Texas-Mexico link with that one. This baby did travel to Mexico. So what has come of this is the baby was also seen at Denver Health Emergency Department. So there's a time frame for anyone who might have been in the emergency room between 10:30 and 4 o'clock on April 6th as far as exposures go and potential exposures. If you're fully vaccinated, the risk is not there. If you're unvaccinated or undervaccinated, then those people are the ones who need to pay attention to those times and dates. So basically, and I'm just going to put this out there because it may happen when the next case occurs, is that the definition of an outbreak, just so you know, is 3 or more. So once we get a 3rd case in Colorado, they will label Colorado as having an outbreak of measles. Okay. So The recommendation now is for children, for babies that are less than a year old, because typically you get your first vaccine at 12 months. And you normally would not administer it prior. With this instance of the measles, they are recommending infants between 6 and 11 months of age can get 1 dose of MMR. If they are traveling to an area where they know there is a measles outbreak going on. So and then at that point, once the child turns a year, they would still get the regimented at 1 year and then another dose, a second dose. So you'd still get 2 doses after. But if you have a baby that you're taking somewhere where there's a known outbreak, you probably want to consider getting an MMR before you go. You have any?
You become an outbreak.
You know, I would assume yes, but I don't know for sure. I wouldn't put my paycheck on that answer because I'm not 100% sure. But I would think that once you call something an outbreak, you're going to make, the recommendation is going to be. And it's not going to hurt to give a vaccine to a baby between 6 and 11 months old and then have to redo the series again after they're a year old. It's not going to hurt the child. Right. Right. Yeah.
My mic's not one to work. So kids generally do very well with this vaccine. They usually get it at 1 and then right before preschool. And it's a live vaccine, but they generally do very well with it. And we don't have a lot of side effects or issues specifically with this one. I know I had a bad reputation for a while, and that's why we're dealing with undervaccinated populations right now. But it's a very safe and effective vaccine to give. So.
And just to put it out there for the actual address of the Denver Health Emergency Department that was visited, it's 777 Bannock Street, Pavilion A. That's the building that if you were there on Sunday, April 6th, between 10:30 and 4:30, you need to be thinking about your status. If the other thing that I would like to say is it's super, super important for and it's actually in the HON that just came out to you, which is Health Alert Network. That's this notification that we got. It's really important for providers if you suspect. Don't wait for the confirmed measles result. If you suspect measles and you're testing a kid or an adult for that, to notify public health right away, because there's work that we can do to decrease the potential if it does turn out to be measles. So with this baby, it was an immediate notification of CDPHE, and they were on it right away. So it's definitely going to decrease the number of people that have been exposed. So that's super important for providers to let us know. Better to be safe than sorry. So any questions about the measles? Anything? Okay. Okay. And you can get the vaccine. I mean, we have the MMR vaccine. The hospital has it. I believe Walgreens and City Market. I think that is what Julie put on here. Yeah. So there are avenues to get the MMR. So there's not barriers to that. So, okay. That's pretty much all that do you want me to go through communicables, or are we're good with moving on with other stuff? Okay. I had just put measles on there because that is kind of what's going on currently. So, okay. So let's move on to the 2025 Community Health Assessment Report. And Katie's going to kind of lead us through this, and you got it electronically, I believe. And the way this works is we are presenting it to you all, and then once you say, yep, looks good, you approve of it, then we send it to the state. And because this is one of the steps that we have to turn into the state. And this is basically a summary of what Katie went over last time from our survey results, along with data compared together. And this is what it showed. So, Katie, you want to guide us through?
Yeah, thank you. So last time, I think it was our last Board of Health meeting, I walked through some of the results from the survey. Y'all remember that? So this is now the results of the survey combined with secondary data from the state, from some national outlets. And so I'll walk us through this very briefly. There are just a couple of key things I want to point out. But as you see, it's short and sweet. So hopefully people can actually utilize this as a document if they want. And if there's any further information that anyone needs, they can reach out to us and we can help with that. So the kind of the first page here is just explaining why we do a health assessment and what that process is. And then pages 2 and 3 are about the survey, which we talked about at our last meeting, kind of went over some of the highlights there, and a little bit of an overview of Montezuma County and our demographics here. So if you go to page 4, this is where we're kind of starting to look at the highlights, the biggest issues that came up locally compared to some state and national data. So the mental health, okay, let me see here. Yeah, mental health was ranked as the top concern out of 13 issues listed in our survey. And I just wanted to kind of point this out because in 2023, 20% of Montezuma County adults reported experiencing poor mental health for more than 14 days in the past month. So that 20% is obviously a fifth of the population. And that's from the behavioral risk factor surveillance system, and that's a Colorado measure. And then, which is higher than the state, which you'll see a lot of these are, the ones that are highlighted are often higher or more extreme than the state, and I think that is just good for comparison. So then we have, right below that, I know we talk about the suicide rate a lot in here, but just to have some numbers in front of us, the suicide rate currently is 39 suicide deaths per every 100,000 people in Montezuma County, and that is almost double the state rate of 22. So if you're looking at 39 people dying by suicide compared to 22, that's quite significant. And I will also mention that the state has a higher suicide rate than the national average. So we are dealing with a high suicide rate here. The next category is substance use, and often we will combine mental health and substance use when we're talking about doing interventions because something that affects one will affect the other. But in terms of looking at the data, we did separate it for that purpose. So something that really popped out to us was that was the alcohol use. So if you go to the top of page 5, you'll see that 30% of fatal crashes in Montezuma County involved a driver or motorcycle operator with a blood alcohol level of 0.08 or higher. And then something that's fairly shocking is the county's death rate from alcohol-related liver disease was 3.6 times the state average for the period of 2020 to 2023. So if you're looking at the actual number of deaths, that's 55 people in Montezuma County. There we go. That died by alcohol-related liver disease. So that's 55 versus 15 for the state. So that kind of helps paint the picture of what we're looking at here with alcohol-related liver disease. And so those are kind of some of the bigger things. I will just mention that housing costs and basic needs came up quite a bit. I mean, 69% of survey respondents mentioned lack of affordable quality housing as a major concern. Healthcare access was a little bit mixed. We kind of went over this last time, but just as a reminder, some people said they struggled to get care. Some people said it was just fine, not too difficult. And then as a reminder, our number one response to any question in the survey was 84% of people said lowering food costs was a greatest need in the community. So one more thing I'm going to point out, if you go to page 6, there's this measure called years of life lost. And in the past, when counties would do health assessments, a lot of times they would look at leading cause of death. And this is a kind of a newer way to look at a similar statistic. The reason leading cause of death isn't always super informative is because everyone's going to die of something. So years of life lost is a measure to show actually how many years of their lives people are losing to certain things. And so this was really interesting for us. So if you look at this tree map here in green, this is weighted by what percentage of the deaths were attributed to a certain cause. So if it's bigger and darker, you can see how much of the actual population was taken up by that. So if you look at number 1 was unintentional injuries. So the most years of life lost for people in in Montezuma County is unintentional injuries, and that can be car accidents, falls, poisonings, burnings, a lot of different things. The second highest one was chronic liver disease and cirrhosis. So obviously we're seeing that in this graph as well as before. And then third is, again, suicide. And then we've got kind of a few more smaller ones, but you can see those 3 are kind of taking up the lion's share of what's shortening people's lives in Montezuma County. So before I go on to kind of the next steps, any questions so far about that?
Mental health, the 39 suicide deaths per 100,000 people, which is nearly double. Per the state rate of 22, why statewide? Why are we so high? What's the data is showing that, but is there an answer? And
Yeah.
you can't answer that, but
Yeah.
is it just because alcohol is so linked to mental health? Because then you turn and look at the alcohol rates, which are substantially higher. I'm just asking a question.
Yeah.
Do those correlate? Is
Yeah,
it because
it's a good
alcohol is
question.
just so accepted? And
So,
I mean,
okay. Well, the alcohol is connected to suicide. The last time I checked, and this isn't the most up to date, it was probably like 2 years ago, but over 60% of suicides in Montezuma County had alcohol as well in the system. So it is connected to suicide, but that's not the only piece. We don't actually know in the field of suicide prevention, there isn't a causal relationship for suicide. We don't know what exactly causes any single person. What we do know is that the Mountain West has the highest, it's kind of considered the suicide belt. So we do have the highest rates of suicide in the country. Wyoming is the highest, but Colorado is up there in that. And we do see that there is a correlation between people being socially isolated and a higher suicide rate. So again, we can't say that's causing it, but they are connected. Did you want to?
With suicide completion risk, there's certain things that put you at risk for completing. I mean, having a substance use disorder, access to firearms, being isolated, male sex, previous suicide attempts, those all put you at higher risk for completing a suicide in the future. So I think there's a lot of those risk factors come together here, and then lower access to mental health care here. I think those all play together to make our suicide rate higher. Probably statewide. And statewide, yeah, likewise.
I guess that was
statewide.
my concern. Statewide. I mean, I understand that we're more rural and we're a little bit more remote, but statewide, the Front Range is not remote by any means at all. And those numbers have got to be affecting our numbers down here also.
Yeah.
Because of the population.
I haven't looked at it specifically, but I know that a lot of our rural counties are the reason for the high rate for the state. It's not so much the Front Range.
So the 59 counties don't even equal the population of the Big Five in the Front Range. It's not even close. So how are the rural counties? I guess I don't understand that.
Well, so the rate is comparing to 100,000 people.
Right.
So it's a way to kind of like balance it out, right? So even though we don't have 100,000, our rate is 39. So more people may actually be dying in the Front Range, but the percentage of the population would be smaller than ours. We have a higher percentage of people dying by suicide in Montezuma County.
Okay.
That's the same in all rural counties. So that's why the rural counties make the state higher. Does that make sense? It's all statistical, but that's
Yeah.
why it's making Colorado.
I think I get what you're saying. I'm not sure that I'll look at the data more clearly.
Yeah.
Because
Yeah.
it
Yeah,
just doesn't-
yeah, please
Yeah.
do.
Um,
That, I will just say that this years of potential life lost, for me, as the public health director, speaks to, I think this is really valuable information, and it's a valuable way to put it. Because when you think, that lives are cut short by these, and this is telling you how many years are lost. And that's, rather than just saying death rates and things like that, it seems to have power to me to tell the story.
So you're saying if we move to Denver, we'll live longer?
Not necessarily.
I don't want to say that.
Yeah.
I think if we can
You might
remove
die of
it-
something else.
we can remove
You
the
may not
HUOH.
want to live longer.
And Commissioner Candelaria, the second reference on the back is the Colorado Suicide Dashboard. That is a really interesting resource, and you can look at specifically Montezuma County. You can look at what different causes, like the methods for suicide. You can, to some extent, you can look at the demographic information, like age, gender, things like that. Sometimes the data does get suppressed, so we're small, but you can look at like a 10-year period and kind of get around that and see what's happening in Montezuma County. I think it's a really great resource. And I didn't want to fill up this document with all of that information, but it is there available. So,
Yeah, no, I understand that.
yeah.
You may not be able to answer this because I'm reaching back a ways. Healthcare access, are we getting better, worse?
And Dr. Mullen can probably speak to this as a provider as well. And I think that is a challenge probably throughout the nation. But we are definitely, I think it's getting better here somewhat, but there's turnover with physicians as there is with everything else, right? And so when there's turnover, there's attrition. Patients get lost in the shuffle. Patients have to find new homes. It's just, and it makes it hard to get your health care when you need it. Go ahead.
Okay, is that gonna work? So the hospital did a needs assessment for primary care for us, and when we had everyone come on this year without me and Jay leaving, we were gonna be fully staffed as of this upcoming summer. With me and Jay leaving, we're both part-time, so we're losing about 1.5 doctors for the number of people in our town for primary care. So the hospital's closer than it has ever been, even with us leaving, to being fully staffed primary care wise. And that's something they're continuing to work on. They've worked with with their management company to do a lot of just like population data and figure out what our actual need here is in Montezuma County. So yes, there's high turnover. It's getting better than I've ever seen it. But it's something that the hospital's specifically working on. In healthcare, compared to 20 years ago, it's harder for doctors to come out and go straight into private practice because we come out with so much debt, usually. And insurance reimbursement's a lot harder to navigate than it's ever been, and you get less and less for the work you do. And to take a risk like that to start a small business when you have the option to be a W-2 employee, it's hard to make that risk when you come out with as much debt as docs do now. And I think that's part of the drive for more physicians to be employed instead of starting their own private practice. That's contributed to physicians leaving their communities and higher turnover because you have that option. So that's a big picture nationwide problem right now with physicians in rural communities. I do think the hospital is working to to retain their docs and recruit more here. And the stability from the C-suite down has really helped that, because for a while there we were having a lot of turnover at all levels, and that drove out a lot of docs. So I'm hoping things do stabilize, and it's looking like it's moving in a good direction for access for primary care. Behavioral health is another
you up.
monster there. No.
No, to back you up on that, the what we're looking at right now in Montezuma County is we have more primary care physicians per person than the national average, so we're doing better in that sense. But we have fewer for mental health, so and we have slightly fewer for dental health. But so that's why it's kind of a mixed picture.
The other factor too is that when someone calls to make an appointment and they can't get the appointment when they want, or they can't, it's a struggle to make that appointment. There's nothing immediate unless you go to the urgent care or the ER. Like there isn't. I mean, it's very seldom that you'll get a same day appointment if you call and you have a problem. Yeah,
That's a common structure
Right.
for primary care now.
absolutely. I mean,
in this
it's
day and age,
everywhere.
We're trying to use our urgent cares
Right.
and same-day clinics more than
Sure.
just your primary care for urgent care needs.
But what I was trying to get at is, no, it's fine. As an individual, if you meet a barrier when you're trying to accomplish an appointment, you might just give up, right? So that is seen. And then if the next day you hand me a survey to do, I'm going to put that I have trouble accessing care. You see what I mean? So it can be the mindset of the individual too. It might not, like, the numbers don't show that bad of a picture, but if the mindset, if there are barriers in our community that are preventing people from getting in, yeah, there might be docs, but are they hitting barriers? I don't know the answer to that question, but to me, that's something to consider
Well, the
when we're
survey-
talking about access to care. Yeah.
The survey again, like this national data again, showed mixed response. Some people said they had a fine time getting in, and some people said it's difficult. So we had 49% said they struggled, so slightly more, and 42% said it was not difficult. So
And the other thing that I just recently learned was, like, just from talking to Dr. Atwell, she is seeing a huge increase in the number of people that they are having to see on street medicine that are non-beneficiary clients. So some of those people may be able to go to urgent care, right? Or maybe they could have a primary care doc, but for whatever reason, they're seeing a huge uptick on seeing people that are non-beneficiary. So I don't know the answer. I don't know how to get to the bottom of but to me, it's like if that ends up being an issue that we're going to work on, getting the hospital to partner with us, getting access to partner with, what are the barriers? Find out from their patients, what are their barriers? Is there a little survey they can do internally? Did you have trouble getting this appointment? If so, what happened? You know what I mean? I don't know if that's what it is, or if we don't have enough docs. But I'm kind of thinking, and then after talking to Joe Thine the other day, I mean, there has been a ton of work on getting these physicians in, and they do have more physicians coming already lined up. So, yeah.
What percentage?
Add we were talking about this in the benefits committee meeting yesterday for the county. The cost of insurance has gone up, and even the employees are feeling that effect. And several people that I know aren't going to go to the doctor when they're sick because they don't want to pay the out-of-pocket because they're on a high deductible plan. And so there's the opposite of abusing the system, not using the system because you don't want to pay out of pocket. And so it's just kind of a mess.
yeah, and we know that prevention can save so much money and further degradation and illness down the line. So, yeah, it is hard. Any other thoughts for now? You don't have to. It's a good conversation.
I think that I'm going to weigh in a little bit on this mental health thing, because if we got
Sure.
rid of all the ETOH and all of the cell phones that we all pack around and the social media that everybody follows, I think you'd see a change significantly and quickly. And I mean, there's nothing better than going outside and playing in the dirt in a box of rocks. And that's as simple as it gets.
For
So
sure.
it's fantastic.
But this is also
But-
the generation of people that are growing up
Understand
right
that.
now, and this is who we need to treat.
I
So
get
we're
it.
going to do our best with what we can. With the system abuse side, working here as a primary care provider, I saw it less than I did like in Alamosa or in Pueblo, other places I've worked in Colorado. But that's not based on a number or anything, but I definitely saw less people overutilizing the system than I saw underutilizing it.
And I think I would have the question with that situation of, is there a behavioral health issue behind the system abuse use? You see what I'm saying? So I feel like I mean, it could be a substance use, it could be a mental health, it could be abuse in a physical abuse situation, but there's an underlying reason that someone is abusing the healthcare system by coming in every day or calling multiple times a day for help. There's something at the root of that, that's causing that to happen. So it leads back to the behavioral health, substance use, whatever it could be. It's a big umbrella. When you say behavioral health, it's a big umbrella. It encompasses many, many things. But anyway.
Yeah. And to the point about phones and kind of social media use and all of that, we're starting to see, you've probably heard about this in certain places, policies to like ban phones at schools. And so public health is kind of getting tangentially involved in that because it is a mental health concern. And so as this generation is growing up and as we continue to see these rates like in this connection, I think we're going to be talking about this a lot for a long time. So, okay, well, I will just wrap this up by saying, so now we have this information. So now what? The answer to that is that our advisory committee that is guiding this process is going through a prioritization and capacity assessment. So we're looking at, I think there were 7 top things that came out of the survey. I counted at one point there were like 40 to 50 different topics that came up within the survey, but these 7 bubbled up to the top. And so we're going through a process of looking at, do we have the capacity to address this either as a health department or as a community with partnership with other organizations? And that also includes like what is already existing, happening in the community related to those things. For example, mental health, there are obviously a number of things. And then prioritizing along with that what we're going to be focusing on. So the next step will be creating the public health improvement plan, and that's going to be a process I'll be working on for a few more months, and then that will be, when we wrap it up, that will be kind of our 5-year strategic plan that we will be using to guide us at the health department, and we'll be evaluating our progress along the way once we have that. But this is kind of the midterm. This is what we found out. Whoa, is that me? And then we'll have the public health improvement plan that will be kind of our guiding document. So does that make sense? Cool. That's it.
So can we say by this presentation that you're good with this report and we can send it up to the state? With the exception of Commissioner Candelaria. No. No, go ahead.
I mean, I guess, yeah. You can send it to the
want
state.
do you want to look at the data
would-
yourself? Is that what you're?
Well, yeah, because I haven't had a chance to look at any of these, and not that it's going to change anything. I don't think it's going
Right.
to change anything at all. But when do you have to get this to the state?
Well, we don't.
There's no set deadline. It's just for me to be able to say I'm done with it.
Okay,
Well, and,
so-
and it's really so that we're going to move to the next step
Yeah.
where we're trying to compile the priorities,
Right.
of what we're going to,
So you're,
what we're
it's
gonna be
not
working
stopping
on.
what you're trying to do and trying to capture the 7 or 8 items that you're going to look at for your.
if you're
Public
good with
health
that.
Yeah,
if
as
you're
long
good
as
with
those
that,
are-
And I don't have an issue with really that. But again, I would just like to look at a couple of these other.
Right.
Yeah.
No,
Yeah,
and-
no, I think that's great.
Oh, yeah, we could do that.
Which one?
And I think at this point, what I look at this as, this is our roadmap up to this point.
Sure.
To show us what direction we're going to start looking at and prioritizing. That's all this means. So to me, numbers change, statistics change over time, right? So, but I think it's also a resource because it's kind of tweaked your interests, right? You're kind of like, okay, now I want to go look at this. That's good. That's what this is all
Well,
about,
that's-
right?
Yeah,
I mean,
that's really what we
this is
want,
about.
is people
Yes.
to be interested
Yeah.
in this.
Yes,
So-
because this is our community, this is our county, and what can we do to make these improvements? And it's not going to happen overnight. It's not going to be a quick fix. It's over time. That's why these plans. It seems like sometimes, oh gosh, we're not getting anywhere, but everything's over time. It takes time, minimum of 5 years, minimum, to make any change. So, but you have to evaluate it, what you're going to target. And some of these things, public health isn't. Public health is not going to build housing. We're not. But
No.
we know it's an issue. We can absolutely support. We work with Pinion Project. We worked with them with Tawicon. I sit on these different committees to make decisions that they need to have help making. So we do that work, and that's in a supportive role. But what things can we in public health target to help make a shift in our community? That's that's part of what we're trying to figure out with this.
Okay.
That with the care access could be educating the community too. That's something about like, hey, you can't get into your doctor today, but urgent care's there. These are the things available for
Yeah.
you and so forth. So
I think it's all about education, for sure. Because if you don't know, you just don't know.
Do we look back at the last survey and compare and see if we're getting better or getting worse? Okay.
Good question. Yeah, I almost printed it out, but I didn't. But our last survey, the number one issue that came up was behavioral health, which was substance use and mental health
Right.
combined. And this survey this time we asked kind of more questions. So we will be kind of, I think, maybe continuing that just to kind of get a bigger picture. But we're definitely looking at what came out last time. And we had some interventions and we now have the suicide prevention program. That's one of the things that came out of the last time we did this. So continuing to kind of monitor our progress on things like that.
Okay. Send it. Send it.
Okay. we got a 50-50 here. That means you can do your research and look at it, but we're going to send it. Okay?
I don't think that's what. No.
Well, Commissioner Lindsay just said send it.
What's 1-to-1? What does that mean? He wins. No, that's not what it means.
Yeah, we like his
glad you
answer
guys-
better.
So you go to your uncle. What do you say?
One is no action, that's all I'm saying.
No action. See?
You know what it is at our house? Go ask your mom. Or your grandma. How do you feel about that, Mom? Yeah. Send it.
Yes? We sending?
Give me a couple weeks.
Man.
A couple weeks is not going to hurt anything.
No, it's not, but what's it going to change? Are you going to tell us, no, we don't like this?
I don't know.
The results aren't going to look any different
I don't know
because
what
we're
I'm
not going
gonna
to
tell
rewrite
you.
it because this is what the data shows.
So you should always question the data too. Right? Who's inputting the data?
Well,
We did some, and then the state.
All right. Well,
a lot of different sources, but you'll
Yeah.
find on the resources page, you can find it where each one, how they collect it. A lot of them do like phone surveys, and so that's how they're.
because
getting
really
it.
when I'm gonna get way into the weeds now.
This gives
So I'm
you a
not gonna
chance
do
to
it.
call the Colorado Department of Health again.
Correct. Anyway, you're right.
We can
it is
wait.
Not going
We
to
can wait if
change
you
it.
want to.
But I'm just asking you the question. Give me 2 weeks, and I'll probably be with Mom here and say, send it.
So when we get that from you, the thumbs up, send it. We don't have
Yes.
to come back and talk about this
No,
again, right?
negative.
Okay, good.
No.
That's perfect. Perfect.
No.
Then we will send
See
it at
how
that point.
easy that
We'll
was?
do- Yep. Yep. Okay. All right. Let's see. Oh boy, we need a drum roll now. So this is our last Board of Health meeting with Dr. Amanda Mullen, who has been amazing in so many ways, on so many levels for me. And it's been great to work with her, and we wish her and Dr. Anderson such good luck at where you're going and your new life and new endeavors, and it'll be amazing for you guys. So, but we're sad to see you go, for sure. So we just have just a little something from the health department to you, and that. So yes, so that is the sleeping you. And actually, I guess we can just give Dustin some kudos here. So Dustin, our maintenance.
I thought I was going to have to jump out of the way.
I'm like, oh my gosh. So Dustin, we asked Dustin to make that. So he made that sleeping ute for you, so that you can hang it in your house, okay? And remember us and think of us, and same for the gift that's in the bag too. So, yeah. So I know you packed all your stuff up, and you and Jay are not ones for stuff and things, and so we didn't want to get anything big and it would take up a lot of space. So, okay. Good. Okay.
Wait
what-
a minute.
oh.
I get to say something
Oh,
here.
go, okay.
So the first thing I have to say is I don't want to look in the bag because I'm sure there's probably a bottle of Jack Daniels in there, which we just talked about, ET08. So I'm going to assume there's nothing like that in there. But
Nothing to hurt your liver, in other words.
yeah, no cirrhosis.
Yeah.
But do you remember the first question I asked you, Amanda, when you came here?
I can't remember the first question, but I know you'd asked me what a Board of Health should do.
Yeah, and which is going to go into my next question for you on this training, this CO health training, which is a conversation we'll have outside of this room. But I thank you too. I wish you were staying longer, but I wish you nothing but good luck in wherever you're going and what you're doing, and wish both of you well.
Thank you, Jim. Thanks for all you've done for us, too.
Thank you.
Safe travels and many banjo strings.
Thank you, Kent. Thank you.
But I'm disappointed. You worked so hard to get into a house, and now, adios.
We're keeping our house.
Okay.
Yeah.
Ha
The little, she's not selling the house,
All
so
right.
this is good.
It's because we love it here, and people have been really good to us. This has been a good first job in our career, good first community for us to get involved in, and good first home for us. So we may find ourselves back.
So, so obviously, we need to appoint a new medical officer. And Dr. Jocelyn Hirschman, we've had conversation with her. You all have read her resume. You have met her. She could not be here today due to prior commitments in the office with patients. So in the future, she will be able to make those arrangements and block out time so she can come to the Board of Health meetings. This was just kind of a short notice, so she couldn't be here today. But it means signing the contract, which I have here, if you all are willing to move forward and appoint her as our new medical officer.
I move that we appoint her and sign the contract.
And I will second that.
Okay.
So we
Thank
will
you.
sign the contract for Ms.
Okay.
Jocelyn.
And
Yeah.
I have this dated for today, okay, April 8th. So I will bring it over to you. And I already, yeah, Kim is over there, so she knows. Thank you all for appointing her. I think Dr. Hirschman is going to be a great fit for our public health and for our community. She does live here, has lived here for a few years, and she's done a lot of work in the area and on the Hopi Reservation, and she's currently a provider here through the hospital. So, I think it's going to work out great, and I will, once we have that all signed, I'll send her a copy, and then we will have her on board. Any other things you want to talk about here in the Board of Health meeting, or? Okay.
No.
Okay. Does anybody have anything else that they?
I'll just capture you real quick afterwards on that
Sure.
new training that we were just sent again the other day. So
The annual training that you need to do?
yeah, so it's for 25, and I think I'm up to date, other than 25.
No, I think you're the only one who has actually done it. No, he has to do it every year. Every year. Every year.
Get an intern to do it? I don't think I have any intern. Laurel? No, I don't mind doing it. I don't mind doing it. But I'll have that conversation with you.
I mean, the other, and I'll just put it out here, it's an option. Some Board of Healths have the training during the Board of Health meeting. They put it up there, then you all sit through it, and then you can check the box that you've done it.
These are long trainings. The ones
I
that I've
know.
been doing are like
I know
4-hour
they are.
trainings.
If I'm at home, I can violate some of the.
Okay.
This is nothing that I designed, believe me. But it's up to you all. If you want that to be, it could be a whole Board of Health meeting. It's just walking through that training and answering the questions. And I mean, we could do that because some boards do it that way, so that everybody does it and can check the box that it's done. So it's whatever you all want to do.
Okay. I don't think I want to do that because I don't want to be here 4 hours in that training. I'd rather do that at home, where I can actually pause it and get up. And
To
More
me,
convenient.
that's the advantage of doing it at another time, because you can, if you only have
Unless you-
10 minutes, you just put 10 minutes into it and come back at it later. So, but again, that's
Unless
why I've
there's-
never brought it to the Board of
unless you're
Health.
saying you have an intern that can take it for us. I think
No.
that was a recommendation.
That was Dr. Mullen's idea. And we do not have an intern in public health.
All right. That's all I have, and I don't have any recommendations or suggestions.
Okay, I was going to say, do you have any suggestions for next week? I mean, next week, next meeting. So, in July. So, okay. Well, if you think of something that you'd like us to cover, just shoot me an email. Okay. Otherwise, I think we're done, and we can head back over to finalize our
Cake
open
and ice
house.
cream?
Cake and
You're
punch.
gonna come over, right? There's punch.
There's punch.
It's got sugar in it. I won't drink it.
There's
All
water.
Messing with you guys. Thank you. And again, thank you, Amanda. I appreciate it. Yeah. Pedal hard. Play strong. Enjoy your life.
Dr. Hirschman does mountain bike here. If you were wondering.
All right.
Requirement to be on a boarding school.
Sort of retired.
Oh, yeah, I forgot.
I wouldn't say I'm really